Thank you everyone for joining us for our first webinar in our webinar series, Past, Present, and Possible Futures of the Methadone Treatment System. Today's webinar is part one, a history of the methadone system and how we got here. First of all, I want to thank the National Coalition to Liberate Methadone for putting together this webinar and this series as a whole. My name is Juan Tirado, pronouns they, them. I'm a senior associate here at NASTAD on the drug user health team. We are helping host this webinar. And just to let you know a tiny little bit about NASTAD, we're a nonprofit, nonpartisan national association that represents public health officials who administer HIV and hepatitis programs funded by state and federal governments with a focus on dealing with the syndemic surrounding HIV and hepatitis. And that includes drug user health, which is why we are here today. And also a quick thank you to ORN, which is the SAMHSA-funded opioid response network, who assists states, organizations, and individuals by providing the resources and technical assistance that they need to address the opioid crisis and stimulant use, since their funding is what's making this webinar possible. And before we get started and I pass it along to our wonderful moderator, Jordan Scott, I just want to give you a little bit of background on all of our speakers that you should see pinned on your screens today. We'll start with Abby Coulter. Abby Coulter is the methadone liaison for the National Survivors Union, the United States National Drug Users Union, and a member of the NSU Methadone Reform and Advocacy Working Group. In 2011, she and her partner founded MAT Support and Awareness, MATSA, a mutual aid support, advocacy, and educational organization by and for people on methadone and buprenorphine. Our next speaker is Zoe Adams, who is a resident physician in internal medicine at Massachusetts General Hospital in Boston. She was born in New York City and received her MD from the Yale School of Medicine, where she also completed an MA in the history of science and medicine. And she will be pursuing a fellowship in addiction medicine next year. And next, we have Emily Dufton. Emily Dufton is a drug historian based near Washington, D.C. Her first book, Grassroots, The Rise and Fall and Rise of Marijuana in America, told the history of decades of grassroots activisms for cannabis rights. Her second, tentatively titled Addiction, Inc., tells the history of the public development and subsequent privatization of the medication assisted treatment industry. We also have Joanne King, who is the Administrative Director of Harlem East Life Plan with 30 years of experience in addiction medicine. Joanne specializes in developing culturally sensitive, individualized treatment programs for substance disorder, mental health disorders, and general medicine needs. And she is responsible for the development and organization of passionate treatment individuals that can provide quality treatment services. And as I mentioned earlier, our moderator, Jordan Scott, is the Digital Advocacy and Organizing Coordinator for the Pennsylvania Harm Reduction Network, as an experienced community organizer and consultant driving social change in public health. Jordan has successfully led campaigns focusing on harm reduction and equity, including legalizing drug checking in Pennsylvania. And just so you know, we will be taking questions throughout the webinar. You can feel free to put them in the chat. And there's a few of us, me and Allison Gay, my co-worker from here in NASTAD, will be looking at the chat and making sure to collect questions. So even if we don't get to them immediately, be sure that we'll be collecting them and making sure that the panelists get at least as many as we can, and any that we can't address at the moment, we will hopefully be able to address post the webinar, since we will be sending the recording of the webinar to all the people who registered a week or so after after today. Well, without further ado, I will pass things on to Jordan Scott to get us kicked off. Thank you so much.
Thank you, Juan. Thank you, everybody, for being here this afternoon with us. Again, my name is Jordan Scott, and I'm thrilled to be moderating this panel alongside of some of my friends and colleagues. And I'm going to go ahead and I'm just going to dive us right into it. So First, I'm going to kick things over to Emily to give us a sense of, who are the individuals that really pioneered methadone treatment, and how does their vision then compare with how treatment was and is currently provided?
Well, hello. Thanks so much for having me. And so I've got 5 minutes. I'm going to time myself, so I'm going to do this quick and dirty. Here goes my timer. All right. So you probably know a lot of this story. I think this audience is probably already quite well versed in the history of methadone. But if you want to go back a bit, the drug itself was developed in Nazi Germany in 1938 as a potent synthetic opioid when most opium supplies from the South Pacific were not available. It came to the US immediately after World War II as a spoils of war and was sold by various pharmaceutical companies under different names, most notably Dolafine, not named after Hitler. It's the name of Dolor Fin, so the end of pain. It was extremely unpopular as an analgesic, and it was also unpopular as a recreational drug. Herbert Huncke, who was sort of the guy who introduced heroin to the beats, he never really used it. He said dollies were a good way to get through a scare, but not a way to maintain a habit. It was tested at the Addiction Research Center in Lexington, Kentucky, at the Lexington Narcotics Hospital there, where researchers were interested in it, but decided ultimately to not support its development or use because they said that volunteers seemed to like it too much, which is interesting. And it pretty much stayed dormant, kind of playing a role in the underground, but not much until the mid-1960s, when it was revived by two doctors in New York whose names you probably all know, and those are Marie Niswander and Vincent Dole. So you probably know about Dole and Niswander, who were two doctors in Manhattan. Dole was a general physician who was focused on metabolic disorders. Some say that if he had continued that work, he would have won a Nobel Prize. Maybe this is hyperbole, but he was really interested in the human metabolism. He studied obesity. Niswander was a psychiatrist who had actually worked at Narco immediately after the war, and then opened a private practice in New York where she was a Freudian psychiatrist, both on Park Avenue, treating women with sexual problems, and also an office in Harlem, which was being hardest hit by the heroin epidemic of the immediate post-war era. She had spent 10 years there between the mid-50s and 60s, treating a wide variety of mostly young men, mostly Black and Puerto Rican. And she was extremely frustrated by the fact that psychiatry didn't seem to work very well on heroin addiction. What a surprise. So by the mid-1960s, she had become relatively well known about her work. She was quite celebrated for it. And she met with Dole, who had been sort of suddenly put in charge of working on New York's escalating heroin issue. In 1964, they started a series of experiments and tests at Rockefeller University, then known as Rockefeller Institute. And this famously birthed the origins of methadone maintenance. Two volunteers who Niswander knew from her practice up in Harlem were invited to the Institute to live for about 2 weeks while the doctors tested various drugs on these individuals to see their effects. And they found that traditional opiates like morphine and heroin are very short acting, and the volunteers were quite anxious and kind of going in and out of withdrawal quite rapidly. So they decided this probably wouldn't work for, the body processed that too rapidly. Dole, being a metabolic physician, says the body processes this too rapidly. It doesn't work very well. And they tried methadone at a very high level, almost by accident, because they were giving such high levels of heroin. They said, well, we'll try an equivalent level of methadone, and found that the patients were very satisfied. Their cravings were reduced. They felt very stable. They weren't thinking about drugs. They continued to give these patients these doses every day. And as Maria Niswander said, in what the amount of progress they made in a week was the equivalent to what she would have gotten in a year, 3 or 5 with psychiatry. It seemed very sudden, and it seemed very immediate, and it seemed very promising. I have a minute left. So what happens from there, of course, is well, it's like the whole rest of the world happens with methadone treatment. But the origins of it were that it was developed by doctors in Manhattan one who had an interest in physical health, one who had an interest in psychiatry, as a way to respond to the opioid epidemic in a different way, right? To not provide psychiatry, and certainly not to provide incarceration or institutionalization, which is, of course, what Marie Nicewander also saw at NARCO. It was an alternative response developed by trained medical professionals in what was at that point the national center of the opioid epidemic. 442, not bad.
Oh, love the efficiency. And I'll tell you what, I mean, I thought I knew a lot about the history of methadone, and I do, but even in that short 5 minutes, I learned things that I didn't know myself. So thank you. And, leads me to my next question, and I want to bring Zoe in on this one. Looking at what we know about the landscape, then, what role did, Nixon's war on drugs play in how opioid treatment programs were created and implemented in the US?
Thanks so much, Jordan, and thanks so much, Emily. I think this dovetails really nicely after your opening remarks. I'm just going to share my screen. I have a couple of slides. Can everyone see that?
Yes.
Great. Perfect. Okay. So I will also start my timer. All right, so the birth of methadone in the US can be tied to a very particular historical moment. In 1971, President Richard Nixon, in this speech, which the still from that speech is shown here, he declared a war on drugs, unleashing policies that criminalized substance use, incarcerated communities of color, and built prisons. At the same time, there was a heroin epidemic, as Emily was mentioning, that was deeply affecting individuals, communities, soldiers returning from Vietnam. But in the same breath that Nixon declared his tough on crime, war on drugs, and contrary to popular notions of Nixon as an exclusively tough on crime sort of president, Nixon initiated a nationwide expansion of methadone treatment. So from the 50s to the early 70s, 2/3 of the $750 million drug budget had gone towards strategies that targeted heroin supply reduction. But by 1974, 2/3 of this budget was allocated to treatment and research. So a huge shift. And in terms of methadone in particular, the numbers are pretty stark. So in 1968, less than 400 patients across the US were enrolled in methadone programs. But by 1976, the number of patients enrolled shot up to 80,000. So a question that I was really interested in when I was completing my master's work, and something that still fascinates me, is why did this shift happen? So why did Nixon so willingly embrace methadone as a form of treatment and sort of change his tune? Part of the answer, I think, lies in how methadone was studied by physicians and researchers in the late 60s, early 70s, and how it was then packaged to Nixon and the US government. So in these studies, methadone was framed as a way to reduce crime, a relationship that was never proven to be causal. There was little data that focused on patient outcomes and preferences, and overall methadone was understood as a crime deterrent rather than a way to actually treat addiction, and that's what made it attractive to Nixon. Some of the earliest research populations were incarcerated individuals, the majority of whom were Black men. The negative consequences of these studies was that people on methadone were labeled as potential criminals, quote, rather than people experiencing an illness. Thus, government agencies and the Nixon administration devised a way to regulate this medication that had never really been done before. So what happened when these methadone clinics, or opioid treatment programs, OTPs for short, what happened when they opened on city streets? So there was a backlash from many different constituents when methadone clinics opened, from white gentrifiers to business owners. the Black Panthers, even hospital employees, that led to the relocation of methadone clinics to locations unfit for the treatment of patients, like a Staten Island ferry boat, as you'll see in this image, a school basement, among other areas. And this really occurred from the early to late 1970s. And this history has been extensively studied by physician anthropologist Dr. Helena Hansen and historian Samuel Roberts as well. So city officials, police, community residents, journalists also grew very anxious about the illegal sale of take-home methadone in the early 70s. So this clip here is from a front page article from the Boston Globe. These diversion concerns, and diversion meaning the idea that patients on methadone either sell or give away their methadone doses. So these diversion concerns were greatly exaggerated and fueled by the fact that patients on methadone were considered to be, quote, criminals. This led to further restrictions of the regulations surrounding take-home methadone. So the regulations became stricter and stricter. And really, the whole regulatory apparatus became more about preventing diversion and ensuring community safety, rather than about the people who were actually experiencing addiction. And we'll talk about this more. I have 1 minute left, but the regulations have changed very little since Nixon declared his war on drugs. It is, the methadone treatment system is a system that has coercion, stereotypes about crime and addiction, and racism baked into it. And that's part of the reason why Nixon embraced it. He was the president that ushered in the treatment era of addiction, as I've described, but it was more complicated than that. Methadone is a form of treatment, but with a million strings attached, as many people will speak to a little later on. It's a system that has always been more concerned about crime prevention than medical care and rehabilitation. And I think to move forward and dream up new ways for dispensing methadone and thinking about methadone reform, this history really needs to be front of mind.
Thank you so much. And, so often when we have conversations around, what are the biggest barriers and issues with methadone treatment in the US, it all comes back to, at its core, this carceral setting, right? And how we look at people who use drugs, how we look at people who are on methadone. And it's still, even for a lot of people that on the surface are supportive of, using medications to treat opioid use, for many of them, when you dig deeper, it's really, I don't support this, but I'm going to let you have it. But you need to prove, that you want this. You need to justify why we should allow you this privilege, instead of looking at it from the space of we're meeting basic human needs, right? And so, considering the war on drugs and the influence that, the Nixon era had, how does that still, 50 plus years later, still continue to shape how we deliver treatment today? I'm going to throw that to Zoe and Emily.
Cool. Yeah, I would just like to say a little, it's going to sound weird, but a little defensive of Nixon, actually. So I think the focus on the law enforcement origins of methadone is important. But I think sometimes we, like in 1971, when Nixon does announce this new front in his war on drugs, it's actually it's a little bit different. From 68 to 71, campaign trail to when he does this new announcement, it's very law enforcement focused, right? It is law and order. It is increase arrests, put up brand new streetlights, get 1 million new cops in the streets, because it's like urban anarchy at this point, right? It's the late 1960s in America. Like there's riots that in Washington, D.C. wasn't cleaned up for 30 years after the effects. There was some real serious stuff going on. And Nixon wanted to tamp that down. And suddenly prisons are hugely overcrowded, right? Like if you're going to arrest everybody, you have to put the bodies somewhere. And there was a response to it saying like, well, now we have way too many people in here and we've done these tests and like there's a high correlation between the people being arrested and heroin use. And the first original idea was actually to keep people out of cells. Like methadone treatment was developed to keep people out of cells. It was a lot of the people who were developing it were slightly more humane than that. But in 71, things change because A, the election is a year away, and B, there are these massive reports of all of these individuals coming back from Vietnam hooked on heroin, which was being 100% marketed to every serviceman there. Like it was available on the streets for like pennies a vial. Like it was, that was one way the Viet Cong was attacking Americans, right, in response to our colonization and, you know, occupation of their country, which is to, you know, like, well, have this drug, right? You're not going to be able to fight, right? So there's a lot going on. You have basically a media firestorm saying like, oh my gosh, all of these trained GIs are going to come back to America and go through withdrawal, and horrific hyperbolic stories that they're going to shoot up, you know, country picnics and stuff like that. So Nixon feels the need to respond. And he brings in, he essentially opens a new federal office, an extension of the White House, called the Special Action Office for Drug Abuse Prevention. And that does open all of these clinics that Zoe was talking about. They're all 100% federally funded clinics. We go from, I think, 36 in 1971 to 365 federally funded clinics by 1973. And they're all opened by these these public health nerds. It's like addiction medicine Peace Corps or like AmeriCorps because it's domestic. And so like, you know, but the thing is that the majority of this treatment was actually non-maintenance. So the numbers here, like I have this, the 1975 thing, but it's talking about 1973 numbers. So there's 72,000 people in federally funded treatment, but 48,825 of them are in like therapeutic communities and counseling, and 23,000 are on methadone. Because methadone, of course, is the only medication available at the time. But methadone was like, it was a part of the Nixon response, but it wasn't the biggest one. And I think the subsequent decades, the system has become so awful and so cruel, not necessarily because it was just tied to law enforcement, but because it was essentially privatized when Nixon took away, or when Reagan took away all the money in the 1980s and forced methadone clinics become private businesses that, in conjunction with law enforcement, become these very, very difficult places that totally removed from public health. And that's the problem. So I think that we can bring the origins back to Nixon, but in some ways, just because I've met these guys, like the guys who developed this system, and like they're not horrific people who are trying to like destroy American cities, right? And a lot of the response to it, as Zoe points out quite rightly, was from the communities itself. Communities didn't like methadone either. You know, like there were so many things that went into making methadone really complicated, and we are living with the effects of this very complicated system today. That's like the American thing, right? We make really bad systems and then we just leave them in place. That's what we do best. That's what America does. So that is my one little thing about the origins of methadone, that they really are complicated, and it's really kind of tough to suss out the history of it.
Absolutely. I mean, the broader picture is always more complicated than we like to think. You know, there's so many layers and intersections and nuances and, you know, 50+ years baked into all of that. Zoe, I'd love to hear your thoughts, like really like how it's still influencing, you know, how we deliver treatment today.
Yeah, I think too, when even just looking at the original studies of methadone in the early 70s and looking at these graphs, and really it's, you know, time on methadone and on the x-axis, and then like rates of crime on the y-axis. And I think I was reading these studies as a medical student, and I was like, that's not a therapeutically sort of aligned way to distribute, to convey data, right? And I think that is very much so that ethos is baked into the regulations and is baked into how someone experiences being in a methadone clinic, walking into a methadone clinic today. It does not look like, and again, there's tremendous variability across methadone clinics and across the country. But the methadone clinics that I've been into do not look like doctor's offices. They do not look like regular clinical practices. They are divorced entirely from the first methadone clinic I went into. There was a huge office building with millions of doctor's offices in it, and the ground floor removed all the way to the right was the methadone clinic, right? So people on methadone were not going into the building and going up the elevator, right? And that's often methadone clinics are unmarked facades. They're located in less safe neighborhoods. It's not, they're hidden and they're not meant to be advertised because, as I said, a lot of the not in my backyard community protests concerns that have plagued methadone clinics since they've opened. So I think, and again, the regulations just really haven't changed in 50 years that much. There have been small shifts, but they have not been overhauled, which is something that I think in probably the second webinar you all will talk about a little bit more. But I think that legacy is definitely still felt today, that it's yeah.
Absolutely. There's, I think it's so important that people, largely understand that we can change every policy and we can craft, perfect pieces of legislation, but there also is this culture shift that has to happen across so many different demographics at the same time, because a lot of the policies, that we want, we technically do have in place, but we lack those mechanisms for enforcement and accountability, and we end up in this position of just, chasing our tails, right, and just spinning our wheels, which we will absolutely dive more into on the second webinar. Which brings me to, Abby, as somebody, on methadone, as somebody who has advocated in the methadone space for, years at this point. How does our methadone treatment in the US differ from other countries?
So I think it goes right back to what both Emily and Zoe were saying. This system was built with in a carceral frame. It was built with a carceral frame in mind. So when we look at how we distribute methadone in the US, we've never moved away from that. I've been doing this work, as you said, for years, but I've been on methadone, a person on methadone, for 22 years. And I hate to say it, but in that time, things haven't gotten better. They've gotten worse. We're moving in this direction where, it's 3 steps forward, 10 steps back. We're finally, like we talk about it a lot, since COVID, we're finally seeing, some movement. And this work has been going on for, as long as methadone has been around. There have been, the first methadone advocates were actually, started a drug user union. You know what I mean? So when we talk about how long this has been going on, and then we look at how methadone is distributed in other countries, it's nothing short of frustrating. We treat drug use in the United States as a moral failing. It's this idea that until we start looking at drug use in a different frame, that it runs on a continuum. People use drugs for all kinds of reasons. We are going to continue to be light years behind other countries like the UK and places, Australia, where you can actually walk into a pharmacy and access your methadone. I mean, what we want is just access, beyond a clinic system. And here we have other countries who have been doing this for decades, So the idea that here we are, once again, the United States, who is supposed to be, progressive, and we're supposed to be doing all these things that we talk about. It's like you said, the policies aren't the problem. A lot of these things are in place. A lot of the policies are the problem. I don't mean that, but we have a lot of these things in place that just aren't enforced, and that comes from everywhere from the federal regulations all the way down to the clinic companies that operate the facilities, which we're going to talk more about. But we have members from the union, we have folks from MATSA, from the methadone community, who have left the States and are now in other countries. And part of that draw for some folks was that the system was better. And it's not to say that those systems don't have their own issues, because of course they do. Every system has issues. But the idea that, you know, the freedom to access methadone in a system where it is, you know, for all the folks, you know, from the medicalized perspective, to be able to walk in and access your medication just like anybody else, to not feel as though having a one bottle to take home is a privilege. I mean, one of the things that they don't hear in other countries where methadone is provided is that your take homes are a privilege, not a right. So the idea that your medication to even access it at home is a privilege that actually can be revoked indefinitely. Those kind of ideas are what also keep people from accessing methadone or from even embarking on any kind of journey that involves methadone. So I think when we look at the way other countries are allowing folks to access their methadone, we should be following suit, but instead we get a lot of opposition for even access beyond the clinic walls. So if you look at, you know, I think Australia comes to mind because we have had one of our folks just recently move. And, you know, there's been, check out that there's some really good articles, filter articles that she's written about her experiences in Australia and how they compare and contrast to what she's experienced in the United States. I mean, everything from, you know, violating her rights as a disabled human being, you know, the way that she was not able to access treatment services because of being open about her drug use. I mean, like, those are the kind of things that when we walk into a facility, we don't expect to hear. You know, we're there to access the treatment. We're there to access safe supply. Some of us are there to access safe supply. So when we look at it from through a different lens, then maybe we can start moving forward as well as some of the other countries have, but we have to get to a place where we can really start rethinking or unlearning what we know about drug use and people who use drugs. I think the percentage last time was, you know, out of 100% of people in the United States who use drugs, 7% have a substance use disorder. Only 7%. So that means if you're thinking about that in that context, 93% of the people who use drugs don't have a substance use disorder. But methadone is the only safe supply that we can currently access. So, you know, until we look at drug use through a new lens and unlearn some of the things that we've learned, we're going to keep, you know, looking to these other countries that are doing it, in my opinion, far better than we are. And we just keep falling further behind, and our numbers continue to grow. You know, our overdose numbers are the supply that we're seeing, you know, on the street. It's so dangerous. And the idea that these barriers exist at a time when, you know, people are dying in record numbers. Somebody is dying from an overdose right now. You know, the systems here are failing us. I mean, and they're not in other countries. They're not failing. So I think that's something that, in hindsight, you know, we really have to begin to really think about what pharmacy dispensing methadone looks like. And we always hear, you know, it's too hard to do it. It can't be done. You know, you know, it's a problem getting buprenorphine to patients. Well, those are real problems that exist, but we can't just continue to talk about them being the problems. We have to move towards solutions.
Absolutely. You know, so much of it, there's so many, you know, core issues that come up over and over, you know, these, you know, kind of reoccurring themes. And so much of it is just recognizing that people have a basic human right to access care, whether it's medical care, behavioral health care, like it's a basic human right. As somebody with undiagnosed health issues, my endocrinologist would never withhold refilling my medication because I wasn't following my treatment plan, or because my blood sugars weren't in, you know, the target range. Like I would never have my care withheld because I hadn't met certain standards. Because we should always be measuring, like, where is the greatest potential for harm, and keeping people safe should always be, you know, the core of what is driving our work.
Agreed. Yeah. And you know, the other aspect to that, one of the other barriers that we deal with is, you know, the mandatory counseling and things like that that don't exist where other services are provided in other countries. You know, these things need to be optional. There has to be autonomy and, you know, just basic human respect provided to the individual who is trying to access life-saving medication. So I think, you know, the barriers that don't exist outside the US for accessing methadone those are the taillights we should be following. You know, those are the programs that are working. I mean, I think it was Switzerland, you know, when they had not implemented methadone in that fashion until, you know, they had this huge crisis. And literally, I mean, it's as simple as methadone wasn't accessible. They had this huge overdose crisis. It was accessible. And now the numbers have, I mean, I don't have the exact numbers, but they have been reduced significantly. So, I mean, just thinking like, I know it's not that simple, but really, I mean, we saw how fast when COVID hit, we saw how fast, you know, the government rolled these things out and there was no time to waste because people were dying. But we don't get that same response because the fact remains that, you know, we are drug users and we are seen as, you know, I mean, less than worthy of treatment at the very least. And unfortunately, in a lot of space, far worse than that. So, I mean, I think that's the other thing, the barriers that exist outside of what is actually needed by the individual. And this idea that, you know, methadone clinics, the websites look great. They say they provide patient-centered care and this and that, but what you receive is anything but.
Absolutely. And I think a much needed conversation has to happen around what does it truly look like to provide person-centered care? What does it look like to build systems that revolve around respecting people's autonomy and empowering their agency? You know, working collaboratively together. You know, I work with a dietitian and also a nutritionist, and I had the autonomy to choose who I wanted to work with and to shop around. I can do that with all of my medical providers, but if I was somebody who was still on methadone, I have exactly 2 options in where I live that I could go, and if neither one of them delivered competent care, like, I would be forced to choose, like, the lesser, you know, well, which one is, you know, somewhat better, right? And again, we very different standards, and we're at a point where we can't ignore those standards anymore. And so leads me to, I'm going to throw this question over to Joanne. Looking at, you know, the conversation just thought, you know, thus far, how have, you know, issues around race and other forms of oppression affected the way methadone treatment has evolved in the US, both, you know, policy and practices, and as well as, you know, those cultural aspects?
I think fundamentally with the policies, and I hear everybody talking about them, and you don't bear in mind that they were designed to stop crime and to try to control communities, but they were not designed to save the lives of the individual who was actually had the substance disorder. So the mere foundation of the policies is the real problem, and the crux of it is. And when you look at, you know, even the Nixon administration, and you look at some of the Black mayors that was in major cities during that time that was trying to get a hold on the heroin, trying to get a hold on the crack cocaine, and the essence of the individual being served was lost. You know, it became more of a political jargon and a political sense of control. And when you talk about medications, when they come out and they do commercials and they're saying how this new cancer medication is saving lives, this new diabetes medication is doing A, B, or C, methadone never got the opportunity to promote itself in that fashion. So the individuals that needed it, as well as the family members of those individuals, never really was able to develop the knowledge base to help them develop a pride, an understanding, a want to. So the system itself has worked against the community embracing it. It's worked against the person who is on methadone being able to say, hey, I'm on methadone. I'm living a good life. My children are going to school every day. I'm paying my taxes. I'm voting. And the people who have done well, you know, historically in the city, they hide. You know, you still have discriminatory practices with jobs. If someone tests positive for methadone, how do they explain it? Does the person still employ them? Does the person understand that it's a prescribed medication and drug? So there's a lot of gaps that have existed. And I think that when we look at cultures, you know, there's a culture amongst substance users, and the heroin addict was the least desirable one. You know what I mean? It was like, oh my, that was the junkie. That was like defined as the worst. So the culture itself stigmatized itself because of what was happening, you know, from the outside. So, and I think that in terms of taking it forward, you know, moving it forward, I think that it's very important that we do listen to the individual that is going to need the services, that wants the services, because, you know, they know best. And when you just put yourself and say, you know, okay, you know, I went to college, I said, okay, I'm going to do 4 more years of school, okay, you know, and you can see where you're accomplishing something and it's time limited. The way they designed methadone is like, well, will I ever be able to, you know, come one time? Will I ever be able to pick up a month's supply? So it wasn't designed to empower the individual, because it was really designed to control the individual. And what happens within cultures, within societies where people are being controlled or they want to be controlled, you know, you have kickback, you have hidings, you have you know, just the continued, you know, miseducation. And I think that at this point, the practices that have come out of the policies, you know, in New York City and in New York State, providers have tried to do the best that they can. But I think, like a lot of other things that we're faced with within our system, is that if we don't accept the fact that the foundation was never where it was supposed to be, it's just like we're patching, you know, we're putting a Band-Aid on the real problem. So, you know, culturally, it just, it missed the heart, it missed the passion, because a culture is your way of life. And in no way, shape, fashion, or form did the policies take into the consideration the ways or the lives of the individuals that they were servicing.
Absolutely. And I want to address Kate's comment while we, you know, kind of wrap up this history portion. I'd love to hear, you know, everyone's thoughts on, you know, the difference between prescribing methadone versus dispensing it, and like where that came from, why we have that distinction.
I can speak to that. So one thing that people should know is that if methadone is prescribed for the indication of chronic pain, you can get it at a pharmacy like any other medication. So I'm prescribing methadone for patients who, some of whom actually have co-occurring opioid use disorder and chronic pain, but I prescribe it under the indication of chronic pain, and they can get it like any other medication, right? So that is such a, even just that simple fact is so clear just in terms of the difference in how we regard people with a substance use disorder, right? And how much more regulated it needs to be. And I think, as I sort of mentioned, fears of diversion, so selling or giving away methadone, really informed how strict the regulations were. So I think that is at the root of, and Emily and Joanne and Abby jump in too, but I think that's really at the root of the like dispensing versus prescribing tension or compare contrast. Yeah.
I think that the decision to view it as a social service ill in opposed to a medical problem is where the disparity comes in at. Because, you know, if I have diabetes, you know, I can go, and even if my sugar's high and I go into the emergency room, they quickly give me a shot of insulin, 2 shots of insulin, how many ever, to balance me. Then they may maintain me on a medication. But if someone is overdosing and they give them Narcan, you know, it's not about, you know, okay, let's talk about how you can do this where you don't overdose. It's about, well, did you tell them about going into treatment? Well, did you, you know, so it's a
Right.
whole nother perspective that comes with it when you don't view it as a public health issue, but you look at it as a social service or social ill.
Absolutely. Emily or Abby, did either one of you want to weigh in, sorry, before we move on to the next portion?
I think you know, just to what Zoe said about, you know, the diversion being the issue, I think, you know, and we question this constantly, like, where did the fear, you know, this idea, like, there's no data that supports that, you know, diversion was such a problem. You know, we often joke around that, you know, some dudes sat around a table and just decided, like, these are drug users. Like, we need to make this as punitive and as strict as possible because they can't be trusted. You know, they don't have agency over what they're going to do. So I think, like, you know, and we joke about that because a lot of times if we weren't joking about it, we'd be crying because it's just, you know, I was one of those people that felt like I was broken. Like, methadone clinic system taught me that I had this chronic relapsing disease of the brain, you know, that my disease was in the parking lot doing push-ups, waiting for me to, you know, mess up. And it wasn't until I moved away from that way of thinking and had access to take homes where I wasn't inundated with that stigmatizing information that literally, you know, we talk about it a lot. The apathy in the line at the methadone clinic is palpable. You know, this idea that, and I have privilege to speak out about my drug use. I just want to put that out there. Like, I have privilege to speak out about my drug use in a way that, you know, I feel a responsibility to do so for everybody who can't, you know, for the people that we are no longer with us. And when I think about the reasons that a lot of folks are no longer with us, that's why, you know, these systems, these are the barriers that continue, you know, just like with the diversion is not all bad. You know, there are a lot of people who can't access treatment. So I'm of the belief that when there is diversion, it's going to save someone's life, you know, but the idea that diversion happens like this, I mean, look, take homes were expanded during COVID and the bottom didn't drop out. As a matter of fact, we saw things that we've, you know, that were in stark contrast to this idea that diversion is so constant. So that was really all I wanted to add.
Yeah, absolutely.
Yeah, and just I think what really sucks to me is that, you know, methadone is considered the gold standard, the most evidence-based medical treatment for OUD. And there's about 2,000 clinics across the country right now, which is the most there's ever been, actually. Like, this is an all-time historical high. But you compare that to, like, Jordan, you were talking about the doctors use, I just like Googled it real quick, and there's 8,000 endocrinologists and there's 106,000 dietitians. So methadone patients cannot vote with their feet as one can do in many other forms of medicine. Like, if you don't like your clinic, if they're treating you horribly, you may not have a lot of other options, especially in certain states that don't allow clinics at all, right? There are various levels of bureaucracy in this medical field that don't exist anywhere else. And that's what makes it really unique. The other thing, of course, is that, like, you're in you know, a diabetic shock, you go to the ER, like, and you get your insulin, and the alternative to getting that insulin, of course, isn't arrest, right? Like, diabetic shock isn't going to get you arrested, whereas possession is. So it's a troublesome field because it is medical, but it's very quasi-medical, and it kind of exists on the parameter of all of this. It's like the center of a Venn diagram of medicine, industry, politics, and law enforcement. And at the center of that essentially is the patient being exploited. And then we're shocked when we have like 100,000 overdose deaths a year. It shouldn't, you know, it shouldn't be that surprising in a system that's set up to fail.
Absolutely. And it's a great, flow into our next section. And, I have seen and experienced the worst of both our treatment system and our healthcare system. But when I have had to seek emergency care for my non-drug related health issues, it even then is still such a stark difference to when I have had to seek emergency care because of because of a drug related issue. Night and day. And as Emily mentioned, in so many parts of the state, I would say probably the majority, people don't have the privilege of options. We force them into a position of you have to take what you can get because the alternative is nothing. And it's sad and it's frustrating. And I know it causes so much anger because people shouldn't be forced into having to accept substandard care. Um, being kind and being respectful should be the bare minimum starting point, and really shouldn't be something that we are applauding when it does happen. So we learned a lot about where we started and how methadone treatment has evolved and over the last 50 plus years. And so looking at today, where we are in the midst of a public health crisis like we have never experienced before. We have shifted into a place of an almost entirely synthetic drug supply that is rapidly evolving faster than we're capable of keeping track. But we know that on the behavioral health side, the wheels move ever so slowly. So I'm going to throw this first to Joanne and Zoe, but Abby and Emily, please also jump in. What does the typical clinic structure look like?
For within New York City or New York State, we have had the I guess the option, the pleasure, and the flexibility to obtain different licenses. So I actually have 2 addiction medicine licenses, 1 outpatient mental health license, and then I have a primary care general medicine license. And my idea and vision was to create a place that someone can come for help. So it didn't make a difference whether you were coming for methadone, Suboxone, Vivitrol. It didn't make a difference if you were coming for your diabetes, your HIV, your Hep C, alcohol, crack cocaine, marijuana. So we're located structurally within one facility, and everyone comes in. The struggle, I think, for programs in New York State right now is really not so much centered on the guidelines, because the federal guidelines since COVID have given us a whole lot more flexibility to give take-homes, to not utilize toxicology as the only tool of recovery, to understand that a person can lose bottles, and it's okay. Just, let me tell you a little bit, about that. So we've gotten that leverage, but the professional credentials that an individual who is a substance abuse counselor has to have now is different from 15 years ago, when someone who had a passion because they themselves had walked that walk could come in and communicate with that person sitting in that chair. They're trying to incorporate that through a peer support component, running alongside, quote unquote, your professional component. But I think that once again, that peer is treatment, that peer is recovery, not to run alongside the LMSW or the licensed mental health counselor or the registered nurse, but to be the person that has the information, that has the authority to help the individual develop confidence, esteem. I want to, do A, B, or C. I think that we have a concept that's called no door is the wrong door. So you can come in and you can just join the primary care program, and you may be actively using, you may not. But if you don't want to join any of the other programs, that's fine. If you're willing now, you just want to work on your asthma, then we're going to help you work on your asthma. And when you say you want to do something else, then hey, we say, okay, fine. So I think that the co-location of services, the co-location of professionally trained staff, peer recovery staff, patient advocates have really given our clinic a place of change, a safe haven. I think that accreditation for New York State and New York City facilities and just facilities throughout, the states is what is developing. There will be signs, and there should be signs that light up and say, hey, I'm here. You should go inside. We do something, used to do family night, and you'd be amazed how people will walk past your facility for 5 years, 10 years, and when they come in, they're like, wow, I never knew it looked like that in here. I never knew you had computers. I never knew you had clean bathrooms. I never knew you had hallways, that it was real. And I think that that's the most important thing, is that we try to keep and present our facility in a way like, if I had to sit in a facility, this is where I would want to be. So, and it gives people a sense of pride. I think that the clinic structure is one that can be a little intrusive, and we're working on that, where you have the full cycle social and why did you drop out? What do you want to do now? But I think that when they get a little bit more flexible with the paperwork required for the clinic, then you'll also see another step of liberation per se. But I think that, if you look at the federal guidelines and you look at the New York State regulations and things like that, COVID was something that was not good for any of us. But I think in terms of, taking the lid off, it did allow the lid to come off of a lot of punitive processes that OTPs were trying to manipulate around. And now we can openly, do. We do harm reduction now. So if you want to keep using and you want to be here, you keep using, and we teach you how to use in a way that it's safe. If your goal is to be abstinent, then we work with you towards that. So things have become, in a clinic structure, more patient-centered than they were even 5 years ago. So I do invite you guys, if you're in, East Harlem, I'm at 2369 2nd Avenue. We have an open door policy. Please, stop by, because I think that it's important to know that there is movement out there. There are clinics that really care. There are clinics that, look like our own doctor's offices. So please, feel free to come by, take my number, and check us out.
Absolutely, Joanne, and I will take that up. I will take you up on that offer the next time I make my travels up way up north. And I'm glad that you pointed out that there, again, like those layers and those nuances, because aside from also the cultural shift, there is also changes that need to happen from a funding perspective when we talk about documentation requirements. And I have worked in the fee-for-service world. I have worked on, the grant-funded side, and there's pros and cons. I would love and I hope to never have to go through another Medicaid audit again. And that's an important piece, because when we talk about change, we have to recognize that there's all these different components that need to change. It's not just clinicians, it's not just federal regulations, it's not just, doctors or researchers, it's everybody. So I would love to hear from everybody, because I think there's also a lot of misconceptions, and Joanne talked about this a lot. Like, what does the typical process look like for somebody trying to access methadone? Because I think a lot of people have a false picture of like, oh, treatment's easy to get. Let's go a little deeper with that.
I can comment on that. I think, you know, just like with what Joanne said, having been in the system and working with people, you know, in different states, I think to this point, 17 different states, you know, I've advocated for, you know, been a part of some part of advocacy work and looking at the different, you know, hearing about the clinics like what Joanne's talking about and some of the other facilities that since even just, you know, the coalitions come together, there was a point in time where, you know, if you would have asked me if there was such thing as a progressive methadone provider, I would have said, no, oh my God, no, because my experience in that of a lot of the folks that I've worked with has been, and, you know, I used to say, I hate to say it, but I don't because it's a reality, you know, a lot of the doctors and providers, you know, they've come out of retirement. At times it feels like it's scraping the bottom of the barrel because they don't have the knowledge. They're there to fill a spot. They don't believe in the treatment, let alone, you know, have much knowledge around it. So like, for me, hearing Joanne talk and having these experiences, and now I can say, listen, they're out there. There are progressive providers out there that are fighting to end the culture of cruelty that we as people on methadone have to take part in, are forced to take part in every day. You know, we talk about the lack of clinics. I do believe there are a lot of places where it's just not accessible. We know that. But in a lot of spaces, it's not a need for more facilities. It's a need for facilities to move into the space of actual, and Jordan, you said it, it takes nothing to be kind, to answer my question, to not treat me like I don't have a right to know why today I'm getting a urine screen that's dipped versus what I usually get, and you don't answer me, you know, like those questions that, you know, we have that just answer them, you know, and knowing that these facilities are out there and that this work, you know, is happening. Like, to me, that's what this work is about. You know, it's slow, it's incremental, but anything worth doing right can take time. And so I think, you know, as we look at the different structures around methadone clinics, you can attend a clinic in the same state owned by the same company, and it is completely different. Like, there are very little even, you know, similarities as far as what your experience is. And when you walk in for your first time, you know, they expect you to be sick, you know, and then they want you to sit there through 3 and 4 hours of filling out paperwork. And a lot of these things that you're signing, I mean, you're not reading, like, you're sick, you are dope sick. You're sitting there trying to get through these hours, and, you know, and we've had providers that have said, wait a minute, you know, we're going to cut this at least in half. Let me get them dosed, you know, like, just to see that kind of movement. Like, those are the things that matter. You know, we're seeing providers that are looking at, you know, we're not treating methadone, or we're not treating heroin anymore. We're not even treating fentanyl in a lot of instances at this point. So, you know, the way that clinics are set up, you know, the lack of, I think somebody said in the federal chat, but just federal oversight. You know, if every clinic operated at the federal regulatory level, we would have a system that is 1,000 times better than what we're dealing with now. And, you know, New York has always been a place that, here in West Virginia, we long for West Virginia to follow New York's lead. You know, we're still operating in some spaces with a 3-strike rule with Narcan. So, you know, just, you can imagine what our clinics are like at times, but in rural areas. So yeah, I think the difference in the structural differences and the differences in clinic systems is a huge part. It's a huge problem. Try guest dosing from one clinic to another. Yeah.
In terms of the getting access to methadone, because in New York State we have a registry, and you know, one of the unique things about, you know, people is that people tend to go to what they know. So we do also do a lot of readmissions. So in our first day, typically we try not to be paper heavy, and they're with a qualified health professional, a supervisory person. And the goal at that point is really to just collect enough data to get them to the doctor. And then the doctor will dispense to them whatever their starting dosage is going to be. And then that first week, as they are beginning to, you know, get their balance, is when we actually do a full physical and, you know, begin to try to collect other information. But initially, we just, I mean, I think that we share the goal of, I'm in the door now. Just you say this methadone works, just get it to me. So we really try to move them along in the processes that way. In New York State, we can, readmit if someone is coming back and use paperwork from the previous admission. So that cuts down on the whole processes too, which makes it, a better process. So, and generally on day one, depending upon if they are familiar with methadone or not, that's also a different approach. So if someone knows nothing about methadone, we try to give them a speed course and a speed, information as to why it's a 24-hour working medication and the different things that they should look for in the process. We do have admission criteria where we expedite pregnant women. We also expedite people who are being released from, Rikers Island or upstate and have been maintained on medication. We also expedite individuals we know have a history of HIV and AIDS or anything that may adversely, contribute to them going through stronger withdrawal processes. And the system itself is flexible enough. If you feel that someone can't make it through all of that we have, you can kind of just get them to the consent process to say, yes, I understand, I would like to accept, the methadone, and have them sign that and come back around. So we are able to work with individuals a whole lot better now than we were before.
Thank you. Absolutely. Emily and Zoe, did either of you want to weigh in?
Well, I'm a historian. I don't know anything about Joanne and Abby and Zoe are the leaders on all of this. I can tell you about 1938.
Yeah, no, I think just to echo more of just how there's so much tremendous geographic variability. Some clinics, you can walk in same day and get dosed same day. Other clinics, that's not possible, right? Other clinics are only open 3 days a week. Some are open 5 or 6 days a week. So it's, so I think it's just tremendous variability. And the COVID-19 relaxing the federal regulations was great, right? But not every clinic, not every state is forced to adopt those regulations, right? So I think some places that are more progressive, New York, I think Connecticut, like those are the places I'm more familiar with. Massachusetts, they adopted that, right? And that was great for many patients. But a lot of places, I would say most places across the US did not. The clinics, no one was coming there from the federal government saying, to my knowledge at least, saying you have to make these regulations more relaxed, right? So there's a lot of individual clinic-based, state-based discretion that is in direct conflict with the federal regulations.
Absolutely. And I know, especially in, Abby has advocated around this for years now, but how widely just even funding processes vary, not even just state to state, but even within the same state, from county to county. The level of funding allocated by a specific, single county authority, how funding is determined and allocated, and people, so frequently we can't view outside of our own personal lens and our own personal experience. So, it's important when we hear people make statements of like, oh, it was so easy for my loved one to access methadone. Okay, great, because that's that particular clinic, that particular county. Let me tell you what it's like just a couple counties over, or just a few hundred miles across, the state line. And so I think something else that there's always a lot of confusion around, and especially now with the drug supply and how it's constantly evolving very quickly, and with these new synthetic opioids and adulterants, um, what does it typically look like for how, starting dosage and changes in dosage and take homes are determined? And also, like, how does that vary, clinic to clinic?
So I think something I mentioned earlier, when we talk about treating, methadone for treatment, in most ways, we never got treating heroin use disorder right. So the methadone clinic system never got that right. We have so many people that are underdosed. This idea that there's such thing as a high or low dose is just asinine. A therapeutic dose is a therapeutic dose. We really try to break through the stigma around dosing, dose levels. And the sad part is where that stigma starts for a lot of us is within the clinic. At that time and intake when we're trying to get stable. And now with fentanyl as what's being treated, fentanyl use being treated, we're seeing people who, I used to tell somebody, give it 3 weeks. Give it 3 weeks, that and then let's talk. Just give it that much time. Now I'm talking to people that are 8, 9, 10 months in, and they just are not, they're not at anywhere even remotely close to a stable dose, because we are treating a different substance, like the recognizing and we talked about the regulation changes and the COVID. West Virginia, I just want to put this help, like, we had clinics that weren't even aware that those guidances had become permanent. So like, that's a scary thing, when we're looking at the fact that they're not even able, and in a lot of regard, that comes from the higher up, making sure that the clinics are aware also of what's going on, which doesn't happen very often. But when we're trying to get someone stable, there are clinics that are, light years ahead, and they're getting people take homes within the first week, and, to a stable dose, or at least as close as possible, within that first week. I mean, we have clinics that make you wait for an increase 5 days in between, and I think a lot of that comes from the 2015 guidance, but all that was rolled out. And then I want to say, like, right before COVID happened, maybe ACM also put out new guidance around dosing that actually said a starting dose could be 10 milligrams, like 10. It used to be you walked into a clinic, and if you're, depending on the amount you used, of course, like if you're getting, I started out at 30 milligrams and that wasn't enough, that wasn't enough. So starting somebody out at 10, and then the rate of retention, because the doses, they're not people like, and the thing too is, if I'm paying money to access this medication that's supposed to make me feel better and it's not, and I have to choose between paying for my dose or my dope that's going to make me feel better, well, I mean, it's a no-brainer for most, like that's, so like when we look at it, it's like Jordan talked about experiences with this. You do have clinics that, like I said, are getting patients take homes within the first week, because that's what we deserve, like we actually deserve to have access to this medication. It's not supposed to hinder us. It's not supposed to make our lives harder. It's supposed to make our lives more productive, any positive change, which is kind of, something that I'm not sure a lot of clinics even realize as a term, like, so looking at this idea that you can't even get stable inside of 6 months, well, it's no wonder, we have the existing problems that we have. And looking at, titration of your dose and tapering off fentanyl, like we're trying to talk to clinics about this. And I mean, I think this is probably one of the biggest challenges that we face right now, because people are not able to get stable and they're not staying in the clinic. Like that's just, and then they think that methadone, that the medication itself is not working for them, which is absolutely not true. It's a failure again of the system. And then a lot of those folks we never get to see back in the clinic again, because they don't make it back.
I think that it's also fundamental that we get into the schools of medicine and we get into where the doctors are actually being educated at. Because if a doctor, they become an MD and it's like, it wasn't really a specialty for a number of years, so they figured they could just jump in and do it their way. But they really need to introduce it into medical school because it is really truly a very delicate, separate entity and special thing that they should really think about. And also, I think that what would help with that process would also be the organization of scientific data that is collected. So, you know, there's not really a system that programs have to get their information to the county, which gets it to the state, to say that people came into treatment and within 3 weeks we did A, B, or C, and they were stable. You know, they always have the information to tell you how many people who were using opiates on programs were incarcerated, and that's the negative. But we have to be able to organize papers to get out the literature in terms of the value of what we're doing and the success of what we're doing. And we have to be able to educate the practitioners that come in, not thinking that they're going to reinvent the world and save it their way, but know that there's a history here, there's a foundation there. And I think that's really going to be important to understanding dosing, and also making it successful.
What sucks is that we did used to collect that information until it was dismantled by the Reagan administration in 1981. So now we have 42, 43 years of missing data. And wouldn't it be great to like have that again? Because boy, do I agree with that. I agree with the value of that data for really promoting something good. Then it's a big loss to not have it.
Absolutely. And I think this, oh, go ahead, Joey.
Oh, no,
please.
no. I would just say as someone who was fortunate to go to a medical school where I did get some of this training early on, hence my like interest and exposure to the field of addiction medicine, and hence me going into the field, right? Like think of how few people there are so few people who get the exposure that I did, and so few medical students who get to train in hospitals with a positive culture, a humanizing culture, related to taking care of people who use drugs and treating substance use disorder, right? So that's like very small fraction of the US people in medical school. But just the fear and just the fear that surrounds even ordering a methadone dose for a patient or prescribing Suboxone, buprenorphine in the outpatient setting. There's a lot of misinformation, a lot of fear that young doctors have because they just haven't been exposed to it. And it's viewed as other, right? It's viewed as this medication that like, oh, I don't, my license, or, oh, I don't do that. We don't do that here. Or, you know, I've had attendings look at me and say like, oh, well, I don't do Suboxone here, even though there's a need, right? And to me, that is so, it's so not okay. And it's denial of like human rights. Like you're a doctor who needs to treat conditions, right? You should prescribe these medications. So I think there's a culture change slowly happening in like the younger generation of physicians for sure, but it's going to take a while, and it's going to take more awareness raising and more people going into the field of addiction medicine who have a harm reduction approach, who are committed to trying to deregulate methadone, increasing access to methadone, right? So there's a lot of work to do.
Absolutely. And, you know, there was so many parts throughout this conversation where you all touched on how, you know, there was a conscious decision to not view, you know, methadone treatment as a component of medical care. And when we look at the public health crisis and we look at our current drug supply, you know, it really has never been more critical that we start looking at methadone as a component of, you know, of medical care and a public health issue, because there has to be a connection between those that are conducting, you know, drug checking at a lab level and identifying, you know, changes in the supply and being able to work collaboratively with researchers and doctors so that we have this continuous process of evaluating our protocols, evaluating our dosing guidelines, evaluating our withdrawal management guidelines instead of, waiting years. Like xylazine was not a new issue for anybody who was paying attention. But it wasn't until things truly erupted that those within power, actually paid attention to the issue. And we can't afford to keep continuing to make those mistakes. And I know we're coming up to the close of today's webinar, and I want to end it with an open question to everybody on a panel, because throughout this afternoon, we've talked about the culture shift that has to happen and the process of unlearning that needs to happen within these respective groups. Our higher education institutions, our researchers, our clinicians, our doctors, our legislators, our policymakers, our family members, the general public, right? All these individual populations. And so I'm going to pose a question to all of you. How can you, right, because you all hold different respective roles, right? How can you and how are you starting to help others unlearn and kickstart those really important conversations that need to happen? Especially when we're talking about conversations that are going to be very critical, and we largely don't do well with criticism.
So I know for us, MATSA is working on connecting with more family of people who use drugs or have been lost to overdose, and working on a project called Just Say No, as in KNOW. So we've been focusing on also, the mainstream people in methadone, because a lot of the stigma is internalized, and we want to start out with this 101 approach of, let's unlearn the things that we have been stigmatizing with each other. We're sometimes the worst offenders. We create these hierarchies of drug use, and we do these things to one another. So something we're working on is this project called Just Say No, that starts to create dialogue and also bringing families into the conversations to help them understand. Because when we look at, lots of us, the access to clinics, there's lots of parents or brothers or siblings or family members that are having to embark on these journeys, these daily drives, and not understanding why, like their son or daughter or whoever doesn't have any take homes after 6 months, or, so just helping folks to unlearn the stigmatizing language and whatnot, and really starting with a 101 approach, because I think sometimes we forget when we're doing this work that not everybody has the experiences that we do, or has had the opportunity to engage in these kind of conversations, or even access this kind of information. So, we kind of took it back to basics, and we're looking at it from, and having a little fun with play on words, homage to the, Just Say No, Nancy. But yeah, just, and kind of having a little bit of fun with it, just really, and encouraging people on methadone or who are trying to access it to get involved, even if it's, peripherally. There are lots of ways we can help you maintain your anonymity, because there is a huge fear for people to get involved, where, retribution from your facility is a real thing, and it may not be at every facility, but lots of us have experienced it. So, this idea that anonymity is a big part of that, and it keeps people in the shadows. I know somebody mentioned, the compliant patient. It keeps, a lot of folks who are doing well in the program, or, on their journey, in the shadows. So we just want to always make sure that voices are uplifted and heard regardless.
I'm going to speak next because my computer is about to die. But I think for me, one of my goals is, going into this field, for one, as a physician, and trying to align and hear from people on methadone, people with living experience, is a huge goal of mine in terms of unlearning. And then I also write, and I write for the general public. And one of my goals in learning this history a bit was trying to get it out there, really, out of like academic journals and into the hands of as many people, or however people read now, as possible. Methadone has been in the shadows, and there have been so many inaccurate narratives told about it. And I was seeing so much more about buprenorphine, so much more about Suboxone in the media, right? And very little about methadone. And I wanted to try to just get it out there, get that history about Nixon out there, so that people could maybe understand a little bit better the next time they walk past a methadone clinic, why it might look like that, or what are some of the stereotypes that they possess about it. And I think that's the way that I'm trying to get to unlearn myself and get other folks to unlearn as well.
I think for me, the way that we try to do it first is just by being visible. Having a beautiful facility outside and bringing people in where they can feel the love, the appreciation, and the kindness. I think also in terms of being able to be visible at community forums. So it's like, I'm going to talk about methadone and not, where, oh, that's the methadone program again. And really just, well, we're here again, we represent, and we're visible, we're very vocal. We also, I think, do a lot of cross-training when we get referrals in from criminal justice entities and from ACS, because they may be looking for this picture, but we try to kind of work them into seeing the picture a little bit bigger and broader. So it's just about, to me, doing what you do, feeling good about what you do, and letting the world know what you do. You know how you said, I'm going to turn the music up? And that's what you do. So this is it. Thank you.
Yeah, and I have a book hopefully coming out next year on the history of this, the history of the development not only of the methadone system, but also the federal involvement in the development of all of the drugs used in MAT. So the federal government was deeply involved in the development of buprenorphine, naltrexone, and LAM, L-alpha acetylmethadol, a 3-day long-lasting methadone that nobody uses anymore because for a variety of reasons that I outline. So who doesn't want a history of addiction medicine under their Christmas tree or any other holiday celebration? So pick up one for you and all your friends.
Awesome. Thank you so much to all the panelists and everybody for joining us. If you haven't registered for part 2, make sure you do. And I'm going to turn it over to Juan.
Juan, I think you're muted.
I indeed was. Has to happen at least once a meeting for me. I was just saying thank you all so much for such a great panel. And for all participants, we do have a quick survey. If y'all would be so kind as to participate in it. I'm about to put the link in the chat. So if y'all have a few minutes, please fill that out. Otherwise, we will also send it out with the recording and such. And like Jordan said, please remember to register for the second webinar in our series, which is Current Methadone Access, Where Are We Now? And I will be posting that registration link in the chat as well if you haven't gotten a chance to register already. And once again, thank you so much to all our amazing, great speakers, and to a wonderful job by Jordan moderating. This was super engaging. Thank you so much. And thank you everyone for coming.
Thank you.
Bye, everybody.
Bye.
Thanks.